Good evening, professors, consultants, residents, and every attendee of this evening's webinar. I welcome you to the March edition of the YNNF monthly webinar series. This evening, we have a very interesting topic, which will definitely add a lot of knowledge to everybody here present, both those who are already practicing independently and to our residents. It's a topic I personally look forward to, and I'm delighted that it's finally here. We have a senior faculty in the house. I'll leave his introduction to the moderator who will introduce him properly. But I welcome all. Welcome all to the webinar. I hope that everyone. So may I just plead with us to mute our mics as we join in, as I hand over to our moderator for the day, person of Dr. Ahmad Oshol from Lagos State University Hospital. We'll be in charge of the proceedings and we share the dialogue.
Thank you so much, Chairman. Hello, good evening again, everyone. You are welcome to this month's YNNF webinar. We are quite excited to have you all joining us. My name is Ahmed Oshola. We'll continue with surgery for common CNS anomalies 2. A couple of months ago, we had the surgery for common CNS anomalies 1, when we talked about myelomeningocele and occipital encephalocele. Today, we will be talking about craniosynostosis. This is another important CNS anomaly. And then among us, we have two fantastic presenters from Nnamdi Azikiwe University Teaching Hospital, persons of Dr. Chukwudema Okafor, who will be telling us about relevant embryology and anatomy, etiopathogenesis, and classification of craniosynostosis. While his counterpart, Dr. Chike Okeke, who will be discussing the operative principles and steps for coronal and sagittal sutural craniosynostosis, and he will tell us what complications that could arise from these procedures. Today, we are also quite fortunate to have a special faculty among us, one of our own, Dr. Gayand Marcus Boat, who will be helping us to dot our I's and cross the T's. We'd also like to recognize the presence of many of our teachers and international participants here present. So without further delays, we'd like to get to the program proper. But first, a couple of housekeeping rules. We'd like to remind the presenters that they have 25 minutes each to present. And I also encourage them to make judicious use of this time. The questions will come after the presentations. However, participants can use the chat box or the question and answer box to send their questions and comments during and after the presentations. We strongly encourage as many of us to make contributions, ask questions to make this meeting a robust and interactive one. We would also like to implore all participants who are not asking questions to kindly ensure that their mics and videos are at all times off. And I'll call on our presenters, Dr. Okeke Chike, but first, Dr. Chukwudema Okafor. Dr. Okafor, please. Dr. Okafor, kindly share your slides, please.
Okay. Okay, let me share my slide. Can't hear me. Can't hear. Oh, can you hear me?
Yes, Dr. Kafo.
Oh,
Go ahead, Dr. Kafo, please.
I can't hear anybody.
Dr. Kafo, we can hear you. Please, can you proceed with your presentation? Dr. Kafo.
No,
I can hear you. Dr. Kafo, your slides are on and you can go ahead, you can hear you.
Okay, okay. Good evening, professors, consultants in the house, and the colleagues, and everyone present. I'll be taking this YNNF webinar series presentation today on the surgery for common CNS anomalies. Under these headings, craniosynostosis, relevant embryology anatomy, pathogenesis and classification, and Mokafo, Chukudimon. This is my outline. For introduction, craniosynostosis is the premature closure of one or more of the fibrous cranial sutures of the skull, often resulting in abnormal head shape. It could either be syndromic or non-syndromic. Syndromic when it involves other phenotypic abnormalities, and non-syndromic when these are not present. It could also be simple or complex. A disturbance in the balance between proliferation, differentiation, and apoptosis will usually cause premature ossification of the cranial sutures. And environmental factors, systemic diseases, and familial inheritance patterns have been implicated. A good understanding of this etiology and inherent structural and physiological abnormalities will pave the way for the best possible treatment outcome. Concerning history of craniosynostosis, Hippocrates, Galen, and Celsus had made early recognition that exists between relationship of skull sutures and hair shape. But in 1971, Somering discovered that cavarial growth occurred primarily as sutural lines. And premature bridging of the sutural lines with bone will lead to an abnormal skull shape. Otto in 1830 and Virchow in 1851 made similar observations, but they called this phenomenon craniosynostosis. Virchow described compensatory cavarial growth as parallel to the affected sutures, and he was the first to classify skull deformities. Between 1910 and 1920, Cruzon and Appert described craniofacial abnormalities, and we have the opinion that we are part of more complex syndromes. In 1959, Moss hypothesized that cranial base developed prior to the cranial vault, and that cranial base abnormalities produced reticular structural problems. Advent of CT scan in the late 1970s aided more accurate visualization of cranial anatomic deformities. For epidemiology, craniosynostosis occurs in approximately 1 in 2,500 live births. Simple craniosynostosis has the majority of this problem, and they make up 85 to 95% of all craniosynostosis, while complex craniosynostosis forms 15 to 5 to 15%. The syndromic patients make up 15 to 20%, while non-syndromic are more in number, make up 80 to 85% of all craniosynostosis. The risk of affectation, then for any patients affected with a craniosynostosis, the risk doubles for future siblings in that same family if no other family member is affected. But the risk rises to 25% if two siblings are affected, but no other family member, including the parents, affected. The risk further rises to 50% if one parent and a child are affected. There's equal frequency for ethnic populations. Gender predilection will depend on the specific pathology. There are more than 150 craniofacial syndromes associated with craniosynostosis, and they include the Apert-Grisons, the Moenke, the Stratikosin, Jackson-Way syndrome. These are the common ones, and few of them will be described because of this presentation. Concerning embryology, Northern and Leliver opine that cranial cavernous bones originate from neural crests and mesoderm, while Coley was of the opinion that cavernous bones were of neural crest-derived mesenchyme. More recently, Jiang and associates found a heterogeneous origin. They found that frontal bones originate from neural crest, while the parietal bones are of mesodermal origin. The formation of the skull starts between the 23rd to the 26th days of gestation, and it's actually divided into neurocranium and viscerocranium. Neurocranium forms the cranial vault, while the viscerocranium forms the facial bones. Cranial sutures are formed by the 16th week of gestation. The cranial sutures are actually osteogenic forms, which are active areas of bone formation and deposition, and directly affected by underlying tension force of brain growth and dural reflection, as well as some local growth factors. Cranial vault ossification actually starts from the central region of each cranial bone and extends outwards to the cranial sutures. The primary factor that maintains the short patencies is the underlying brain growth, and it has also been known that the expanding dura is osteogenic, supports the growing cranial bones, and the normal skull actually grows perpendicular to each suture. The coronal suture separates the two frontal bones from the parietal bones, as you can see in this image, and the metopic suture separates the two frontal bones. Pointer. Sorry, let me pointer option. So the metopic suture separates the two frontal bones, while the sagittal suture separates the two parietal bones. This is the sagittal suture separating the two parietal bones, and then the lambdoid suture separates the two parietal bones from the occipital bone. The cavernum grows most rapidly during the first 12 months of extrauterine life, with the brain doubling in volume within the first 6 months. Now, between the first 12 months of life and the second birthday of a child, the brain doubles the second time. Following this rapid cavernous growth within the first 2 years, the growth continues in a linear fashion, and when a child is about 6 to 7 years of age, the cranium has attained 90% of its adult size. For the etiology and etiopathogenesis of craniosynostosis is actually heterogeneous. Etiology is heterogeneous, and numerous factors have been implicated in premature cavernous suture closure. One of these included teratogens, which is caused by this drug listed there: valproic acid, retinoic acid, amnopterine, and diphenhydramine. They formed some teratogens that could cause craniosynostosis. Some genetic mutations have also been implicated, and these include the genetic mutations in the fibroblast growth factor receptor 1, 2, 3, and the transcription factors twist and MS2. The others include ERF, TCF12, and EBFN1. Some metabolic disorders have also been implicated and include rickets and hyperthyroidism. Blood dyscrasias like thalassemia, sickle cell anemia, polycythemia vera form part of the problem. And some malformations like coloprosencephaly, encephalocele, some that are associated with craniosynostosis, even though some authors are of the opinion that the inclusion of shunted hydrocephalus as one of the predisposing factors or one of the causes of craniosynostosis has not been proved. The other factors include maternal smoking, advanced paternal age, which normally affects the hematopic suture, and intrauterine methotrexate exposure. Some mechanical restraints, especially in utero, in multiple pregnancies and pregnancies that are affected with oligohydramnios, could also explain a number of isolated craniosynostosis. In some cases, that have scaphocephaly, lambdoid craniosynostosis, or trigonocephaly. Currently, there's increasing evidence that there are genetic underpinnings to both what is called syndromic and non-syndromic. And some authors are of the opinion that dichotomy should be removed, since all craniosynostosis is to have some genetic basis. Many of the syndromic conditions actually follow a familial inheritance and are inherited via autonomic dominance. A disturbance in the balance between proliferation, differentiation, and apoptosis causes premature ossification within the suture. Premature closure restricts growth perpendicular to the suture line, while cavalry growth will continue in a plane that is parallel to the suture. Associated neurocognitive disabilities has also been found with craniosynostosis, and some of the explanations that have been given for this include global intracranial hypertension, focal hyperperfusion, and mechanical deformation of neuroanatomic structures. Concerning classification of craniosynostosis, it can be classified as primary and secondary. Primary has to do with craniosynostosis that are caused by primary defects of ossification. Secondary craniosynostosis are those that are caused by failure of underlying brain growth. According to the number of affected sutures, craniosynostosis can be classified into simple and complex. Simple craniosynostosis are those ones that involve a single suture, while complex involve multiple sutures. Then we also have syndromic and non-syndromic craniosynostosis. It's syndromic when it involves other phenotypic abnormalities, and non-syndromic does not involve other
Dr. Kafo, are you still there? I think we lost Dr. Okafor. Dr. Palike, can you hear us, sir?
I can hear you, sir.
Okay. Somebody advised that Dr. Okafor should put off his video when he logs back in.
Okay, sir.
neutral, otherwise doesn't work from the defense administrating the prime minister is your then
Just define it so strike.
No.
Okay, so while we wait for Dr. Okafor to reconnect, for those that are just joining us, we're in the midst of discussing the second part of surgery for CNS anomalies. We can recall that a couple of months ago, we discussed the fourth part, which involved myelomeningocele and occipital encephalocele. So Dr. Okafor was in the process of telling us about the embryology, anatomy, etiopathogenesis, and his classifications before he had a problem with his network. So we are waiting for him to reconnect.
Network has clicked off.
Dr. Kafo, turn off your video.
Sorry.
Turn
Okay.
off your video.
Okay.
It will help.
Okay. Thank you.
Dr. Okafor, please share your screen again.
Then connect the light source and the one and put for data. That's how we do it.
Okay. Can I go ahead?
Please go ahead.
Okay. Okay. Please. Sorry for the network issue. Sorry about that. Yes. I was discussing the non-syndromic craniosynostosis before the next problem me off. And I'm starting with the first one all over again. The sagittal craniosynostosis, which forms a deformity, cranial deformity called scapulocephaly. It's the most common form of craniosynostosis, present in 1 in 500 children. It has a male predominance of 3.5:1. And concerning the phenotypic features, the head actually attains a long anteroposterior length with or without frontal bossing. It's actually caused by mutations in the tris box and has an autosomal inheritance and autosomal dominant inheritance. The second in line of the non-syndromic craniosynostosis is the coronal craniosynostosis, which is the second most commonest. Is present in 1 in 10,000 children. The male-female ratio is 1:1. Causes flattening of one side of the forehead, actually causing a mild facial scoliosis, which we can see in these pictures. I don't know whether you can appreciate my point. Okay, so it presents with a supraorbital margin that is higher than the normal side, producing what is known as the Harlequin eye sign. When it's bilateral, it causes bilateral flattening of both sides of the forehead. And the skull actually assumes a spherical shape, as you can see in the image on the screen. When it's bilateral, causes an abnormality that's called brachycephaly. Many syndromic craniosynostosis may be associated with unicoronal synostosis. Notable among them is the Menkes syndrome. Now, the metopic craniosynostosis causes trigocephaly and is the third most common. The frequency is 1 in 15,000 children. It has a male predominance of 3.3:1. Here, the forehead assumes a triangular shape like the tail of a boat and causes hypothyroidism, which is reduced distance between paired organs. Genetic and environmental factors have been implicated, and many of these children have abnormality in the short arm of chromosome 19, and they are mentally retarded. A recent study has implicated runs X2. The lambdoid craniosynostosis produces posterior protocephaly, and it's actually rare among the non-syndromic craniosynostosis. It makes up 1 to 9% of all craniosynostosis. Has a male predominance of 4:1. When it involves a single lambdoid suture, there's asymmetric occipital flattening, and it involves the right side in 70% of cases. But it could also be bilateral, just like you can have bilateral coronal craniosynostosis. When it's bilateral, it causes the same brachycephaly that's produced by bilateral coronal craniosynostosis. And this must be distinguished from posterior deformational protocephaly. That's posterior molding that is found in children that lie mostly with the back of their head. This can be produced when a child lies with the back of his head, as part of the Back to Sleep campaign that was done in America years back as a preventive measure for sudden infant death syndrome. For the syndromic craniosynostosis, they are associated with multiple premature suture closure, but they have other phenotypic abnormalities. The most implicated genes are the fibroblast growth factor receptors gene, and the twist gene. The most common forms are what we have mentioned before. Among the common forms, you have the Apert syndrome, which was described in 1906 by French pediatrician Eugene Charles Apert. It was characterized by bilateral coronal craniosynostosis, syndactyly, radiohumeral fusion, and variable cognitive impairments. As you can see, these are the phenotypic features of Apert syndrome. And as you can see, the child has a form of towering skull and some limb abnormalities. The other features in Apert syndrome include mid-face apoplasia, proptosis, a trapezoidal mouth, and a variety of dermatologic manifestations. It's inherited by via autosomal dominant inheritance. And the gene that is implicated in Apert syndrome is the fibroblast growth factor 2 gene located on the long arm of chromosome 10, position 26, and it includes two missense mutations. Crouzon syndrome is one of the syndromic craniosynostosis, and it was described by French neurologist Louis Crouzon in 1912. It presents with the synostosis of the coronal suture, which may be unilateral or bilateral. There's also mid-facial hypoplasia and exophthalmos. The other features that could be seen in Crouzon's syndrome include other cavernous suture involvement, especially the sagittal suture, the anterior part especially. And brachycephaly could be there, hypothyroidism, carrier malformation, hydrocephalus and mental reduction, autosomal dominant inheritance. Is what is involved here, and is caused by numerous missense mutations in the immunoglobulin 3 domain of the fibroblast growth factor 2 gene. Munke's syndrome is another common syndromic craniosynostosis that was described by Glass in 1994. Unicoronal or bicoronal craniosynostosis may be found, and there is also brachydactyly, symbol-like metaphalanges, coined epiphysis, carpal and tarsal fusion. Sensorineural hearing loss and developmental delay are common with this abnormality. A variable phenotypic presentation is associated with Munke syndrome. It is inherited by autosomal dominant inheritance and causes point mutation in Pro250 in the IG2-3 linker region of fibroblast growth factor 2 gene on the short arm of chromosome 4, position 16.3. Pfeiffer syndrome was described in 1964 by German geneticist Rudolf Otto Pfeiffer and presents with brachycephaly and membranous syndactyly of the hands and feet with enlarged and deviated thumbs and great toes. Brachydactyly, ankylosis of the elbows, various visceral malformations like hydronephrosis, pelvic kidney, and hypoplastic gallbladder may be found with this syndrome. When it becomes severe, it forms the skull forms a clover leaf, which is known as Kleber-Jadel. It has a heterogeneous genetic basis, which will involve mutation in fibroblast growth factor 1 gene and various mutations of fibroblast growth factor 2 gene as well. The differential diagnosis of craniosynostosis will include benign skull tumors, which also produce some deformational appearance of the skull, chronic myelogenous leukemia that could form a cavernoid tumor, and hydrocephalus, especially when it's been deformed by positional problems. So thank you very much for listening. These are my references.
Thank you, Dr. Okafor. Dr. Okeke, can you please share your slide?
Hello, my teachers. Good evening, sir. I don't know, can I be heard?
Yes, Dr. Okeke, please go ahead.
Okay, thank you, sir. I will continue with the presentation. I'm Dr. Okeke Chike, and I will continue with the presentation by presenting operative principles and steps for coronal and sagittal sutural synostosis, as well as its complications. These are my outline. Evaluation of the patients with this craniosynostosis will include a detailed medical history and physical examination, as well as confirming the diagnosis with radiologic images. The medical history will get histories like a history supportive of caveria deformities. And in some cases where the patient will have symptoms of intracranial hypertension, you may get some histories like vomiting, irritability, and delayed developmental milestones. Most of these patients are infants, so history of headache, well, we may not be able to elicit that, but it will be there. Physical examination will During physical examination, it's expected that you may see patients with various shapes of head that may include symptoms of shape of scaphocephaly, as the previous presenter has discussed, and the flat head that with bitemporal lengthening or long length, as was previously discussed. Other things that you can see may include the premature closure of the anterior fontanelles. You also be able to see sutural region, that's calcification, in the affected side of the affected side that has the synostosis. And in some cases, you may see symptoms that suggest intracranial hypertension, like papillary edema for those patients that have raised intracranial pressure. Other features that can be seen will include the supraorbital retrusion, as you can see in the coronal synostosis, severe towering, then severe fronto-occipital boson, then increased fronto-occipital length in scaphocephaly, and biparietal length, and mid-face deformities, which you also see in people with coronal synostosis. Typical example, you may see a retrusion of the ipsilateral face, or even hypoplasia of the mid-face, and even deviation of the face towards the ipsilateral side of the synostosis. Now, when we go to the sagittal synostosis proper, is a congenital condition that involves premature closure of the sagittal suture, thereby producing an abnormal elongated head from fronto-occipital region. Hello? Okay. The diagnosis of this synostosis is usually made clinically in most infants. However, the confirmation of diagnosis is by imaging with both plain X-ray and the cranial CT scan. Plain X-ray will show you the region of this area. This is a reformatted CT scan image of a patient with scaphocephaly, sagittal synostosis. As you can see, there is no. Can I be heard? As you can see, there is no. There is premature fusion of the suture, of this sagittal suture. So CT scan can also reveal the features of intracranial hypertension, apart from the premature fusion of the sagittal suture that, like I showed. Another important investigation of choice, MRI, which will show you the relationship of the underlying structures, the brain tissue, and most importantly, the superior sagittal sinus, which is just lying underneath the sagittal suture, to know whether there is any compression effect on the superior sagittal sinus. These are the available as investigation that may aid you after you've made your diagnosis for the management of these patients, including surgery. As you can see, some of them, like the previous presenter has discussed, 2D echo and ECG, which may also help you to know whether there is any congenital cardiovascular illness, which most of them will come with, especially those patients with Apert syndrome. For the treatment, we have different options. It can be non-surgical and it can be surgical. Non-surgical for those patients that are usually the symptoms are not overt and the abnormal skull is not so overt, and there is no history of no history or findings suggestive of intracranial hypertension. You can use a medical helmet, medical fitted helmet that can help to remove the skull. For the surgical intervention, we have different options. It can either be one simple strip craniectomy with a barrel-stave osteotomy. Here, it can either be cranial vault remodeling with excision of the affected bone, trimming and reshaping and fixing it with absorbable plate. Or you can also do pi extended strip craniectomy without fracturing and remodeling of the parietal bone flap. Another surgical intervention that can be done is suturectomy and barrel-stave osteotomies. Then the third one, which is also a common practice, endoscopic strip craniectomy and post-operative wearing of a medically designed helmet for a few months to help in remodeling. It can either be through spring-mediated calvaria and craniofacial reshaping. Then for the surgical approach proper, we are going to discuss suturectomy and barrel-stave osteotomy. The pros of this procedure is that, one, they eliminate the risk of brain damage due to the growth restriction as a result of this premature suture, preventing the brain to grow further. It can also relieve the pressure, very, very importantly, on the underlying superior sagittal sinus, then can normalize skull shape and reduce the cosmetic deformity. For those that may have CSF anomalies like hydrocephalus, this surgery will relieve the symptom. The best time for this surgery is usually done in infants between the age of 4 months to 12 months of age, with the following advantage. First is that the blood volume in this age group is much bigger than in the newborn. So these children can tolerate this procedure more than the neonates. Another important factor is that surgical procedure is simpler as the bone is still malleable and not brittle, as you can see in older children. Also, bone defects or gaps are not a problem here due to the rapid healing of bone in this age bracket. And also, more importantly, the rapid brain growth that usually occurs between the first 3 years of life will also help in additional bone remodeling of this reconstruction. The contraindication for this surgery is older children. That's children that are 18 months and above. Reason is that the cosmetic results are not usually satisfactory. The best option for such people is a total cranial vault remodeling. For the procedure, under general anesthesia and endotracheal intubation, patient is usually laid prone with the neck slightly extended. All the pressure points are usually appropriately padded. Then the surface marking is usually a bitemporal, bicoronal zigzag incision that extends from one tragus to the other end of the tragus. Then this OP sites under standard aseptic condition is infiltrated with 1 in 200,000 adrenaline. This to control hemostasis. This is the image describing what I just explained. As you can see, this is the bicoronal surface marking. I see that's also where you can follow to make your incision. So following that, under a standard aseptic condition with skin preparation and isolation steroid draping, incision is made at this marked area with a diatemy, and hemostasis is usually achieved with a hemostatic clip at the margins. Then a subgaleal dissection is usually done, separating the scalp from the underlying periosteum. Then the flap is reflected in such a way that both the corona and the lambdoid suture can be identified. As you can see, this is the coronal suture, and this is the lambdoid suture. The principle of this surgery is that a CCM-wide strip of bone that is centered at the sagittal suture, extending from the coronal suture anterior and lambdoid suture posterior, is removed with a great care not to tear the underlying dura or injure the superior sagittal sinus. Can I be heard? It's also advisable to remove the entire sagittal suture. It's also advisable to remove the entire sagittal suture, even if it's not fused completely along the whole length. Reason for this is that it helps in normalizing a normal good head shape. So here, a mono cutlery is used to incise the periosteum after you have reflected the scalp and reflect the edges to expose the underlying cranium in preparation for the craniotomy. Then a 2-bore hole that is centered around the craniotomy on both sides of both sides of the parietal scalp, anteriorly just behind the coronal suture, and posteriorly just in front of the lambdoid suture is done. Then the whole of these boreholes are connected and converted to craniotomy with a craniotomy on each side. So this is actually what I'm trying to describe above. As you can see, this is where it has been done. Or if we use this image proper, this is the 2 borehole I'm talking about. This in the coronal suture, that's the anterior margin. And of course, this and this is the posterior margin, and they have now been converted to craniotomy with a craniotomy. So It's also important to know that a brain retractor is passed under the bone that is overlying the superior sagittal sinus and advanced slowly to separate the dura above the sinus from the bone above the anterior and posterior frontal. They cut the anterior attachment. The brain retractor will protect the underlying dura and the sinus. Then the bone flap is elevated from the anterior end, and at the same time, you pass your Addison periosteal elevator to separate the dura from the overlying bone with care not to injure the underlying superior sagittal sinus. Any bleeding points on the dura seen here is usually from a small emissary vein, and this can be coagulated with bipolar diatemy. Then after that, the bone edges are then waxed.
Am I getting any further discounts?
Hello. For the second stage of the surgery, the second stage of this procedure will actually involve performing a barrel step cut on the parietal bones. They're usually about 3 to 4. What is done here is that a sharp Addison retractor is passed underneath the corona or lambdoid suture laterally to separate the dura. Then you now use a craniotomy to make a 3 to 4 barrel cut on the parietal bone, which also includes the corona and lambdoid sutures.
I'll come back next week to do the rest.
Hello.
But maybe when you finish, I have a couple of questions for the next part. Yeah.
Are you ready
Hello.
to go, or?
Yeah.
Like I said, it takes about an hour.
Yeah.
Bart should be here.
Can I go on?
Okay. All right. Sure. Thanks.
That's okay.
The dura should. Oh, okay. Thank you, sir. Okay, thank you. The dura should be depressed in such a way that the dura. Each of these parietal bone segments now elevated off the dura slowly until you get a green stick fracture at its base. Then after that, you inspect the underlying wound, irrigate, then return the periosteum and suture it loosely with a polyglactin 3-0 suture, 3-0 suture. Then, however, if there is any bleeding or at this point, you can place your oxidized cellulose, that's Surgicel, on this bleeding point. Usually some of them may come with hemorrhage. Surgical site infection is also some of the one complication.
It appears we lost Dr. Okeke. Dr. Okeke, are you there? Dr. Okeke.
I'm here. Sorry, net.
Okay.
Problem with network. I'm here, sir. I'm trying to. I don't know even where you lost me.
You are already discussing complications.
Okay. Please, I don't know whether you can see my slide now.
Yes, please.
Sorry about that. Sorry about these network challenges we are facing here. Sorry about that. So, like I said, most of them will, if there is a dura breach during the course of this surgery, the patient may also present with cerebrospinal fluid leakage. Okay, thank you very much. So this is the reformatted C. Can you see my slide?
Yes, please go ahead.
Can you see my slide, please?
Yes, we can.
Okay. Sorry about that. So this is a reformatted CT scan image that is showing a patient that has done this suturectomy. And of course, these are the cuts, just osteotomes you are seeing. Now for the coronal craniosynostosis, like the previous presenter has discussed, a congenital condition that involves premature fusion of the coronal sutures. He has also said that it's divided into both unicoronal, bicoronal synostosis. The diagnosis is both by clinical assessment and imaging technique. And of course, I've talked about how they may appear in a clinical assessment where you see the flattening of the affected side. Okay, my colleague has talked about that. There may be bitemporal elongation of the skull and so on, and the orbital retrusion, and of course, shallow orbit also. Now, for the investigation in plain X-ray, it usually appears as a thickened bridging across the affected coronal suture line. Then 3D reconstruction will demonstrate an immature fusion of the suture of the affected side. It can also show you some of these features that you can see. You can see that if you look at here, you see that there is flattening of this forehead when you compare it to this area that is not affected. If you look here, you are going to see the coronal suture here, but along this side, you can see that this place is fused. Then you can see that this orbit is, that is the right orbit is shallow relative to this side. And of course, there is hypoplasia of this side of the face. So MRI will also assess the underlying structures, just like you see in scaphocephaly, and to show you whether there is any other associated congenital anomalies, maybe callosal agenesis or any other structural involvement of the brain, whether the brain also developed very well. Now, for the treatment options and alternative, once coronal synostosis is identified, the treatment is usually surgical. And these are the different treatment options that are available. They include simple strip craniectomy, endoscopic sinustectomy, or frontal-orbital reconstruction. The objective of surgical treatment in patients with bicoronal synostosis is to correct any craniofacial deformity and decrease any possible raised intracranial pressure. And this is usually achieved through increasing the anterior-posterior diameter of the calvarium, as well as remodeling the frontal-orbital area. Excuse me. However, for patients with unicoronal synostosis, the main aim is mainly to correct the asymmetry of the frontal bone and the frontal-orbital bar. Strip craniectomy has lost its support after it was found to have a high rate of recurrence post-operatively and a less than optimal aesthetic result. Therefore, most people prefer frontal remodeling with advancement of the orbital bar. This gives a better cosmetic appearance. Indication for this surgery is usually for correction of cosmetic deformity, like we've said. And if there is any presence of raised ICP, is actually an absolute indication for the surgery. The contraindication, there is no absolute contraindication. However, a relative contraindication is if there is a presence of microcephaly, given that most of these patients will not benefit from the remodeling effect that will happen, that will come from the growing and expanding brain post-operatively. For the procedure, this surgery is usually done in a facility. It's a multidisciplinary approach with which may involve the neurosurgeon, the pediatrics anesthesiologist, intensivist, maxillofacial surgery. So it's multidisciplinary. Patient is usually positioned supine, and the head is laid on the headrest. A bicoronal incision is performed down to the periosteum and the forehead flap, dissected subgaleally. However, about 1 cm from the orbital rim, this dissection is now moved to subperiosteally. The aim is to expose the orbital nerves, which is usually identified in the supraorbital notch, and release it and preserve it. You also expose the nacium and the orbitozygomatic sutures. Now, a bicoronal bone flap that is designed across the parietal bone is raised, encompassing the coronal suture, and you now advance it forward through the temporal bone and the sphenoid bone and completed it anterior. That's, you advance it forward towards the supraorbital rim. Then the entire supraorbital bar is released using a sagittal saw. This is performed superiorly at the level of the orbital roofs, medially from the nacium and extending laterally to the orbitozygomatic suture. So this is what I'm trying to say. So this is the supraorbital ring that we are going to bring out from osteotomy. Raise it out. Then, now this entire supraorbital bar is removed. And when you remove it, you remodel it by advancing the synostotic area forward. That's reshaping it and trying to advance the synostotic area forward, while you mildly push the contralateral side that is apparently normal slightly backwards so that you get a normal contour. Then after this, you now fix this supraorbital rim or bar on the base of the nose. Then at the end, this supraorbital bar and the frontal bone flap are now reattached together using a vicary suture. So this is the flap that I'm talking about, which is raised, pushing, encompassing this coronal suture, thereby creating another coronal suture around this area. So when you advance it forward, to gain the defect and replace the synostotic area, this place. Then this is the supraorbital bar that I talked about that you are going to remove. When you now remove it, let's assume that this side is the synostotic area. You try to advance this side a little bit forward while trying to reduce this side a little bit backward. That is the remodeling I'm talking about. And after that, you replace it back at the base of the nose. Then also now affix it with the new frontal bone flap that you have raised. The complications that can arise from this surgery may include bleeding and subgaleal hematoma, then injury to underlying brain, like brain contusion, then, like I said, local infections, wound breakdown, that surgical site infection. Then if air embolism can also be a complication, especially if the head is elevated up to 45 or above 45 degrees. Then patient may present with a CSF fistula if there is a dura breach. Even after this surgery, you may still see some residual facial asymmetry and calvarial defect, and some of the patients may present with a hydrocephalus. So in conclusion, treatment of craniosynostosis is a multidisciplinary, and once made, is usually corrected via surgical intervention with the aim of improving aesthetics and reducing any possible raised intracranial pressure. However, the best and safe surgical approach should be used in order to get a better result and minimize recurrence. Thank you very much for listening.
Thank you very much, the presenters, Dr. Okafor and Dr. Okeke. Very good job. This is the time for questions, clarifications, and contributions from the participants. It appears you can also use the chat box. So we have some questions already in the chat box. Dr. Ibe Iwoko wants to know that is craniosynostosis intrauterine deformity or extrauterine? That is our first question. The next question is, how many fontanelles are there intrauterine and how many postnatal? Presenters, hope you are noting these questions. Dr. Okeke, Dr. Okafor.
Hello.
Can you hear me?
Hello. Yes, I can hear you now.
Okay.
Is
You have
Dr.
some
KK talking?
questions. Okay, Dr. Okafo, you have some questions in the chat box ready. Let me read those out, pending when we have people raise their electronic hands up if they have questions and contributions. So the first question is if craniosynostosis is an intrauterine deformity or extrauterine. The second question is how many fontanelles are there intrauterine and how many postnatal? And the third question is, are there grading scales for the severity of craniosynostosis? So you can answer all this in any order you wish. So if our participants have any question, they can indicate by raise of the electronic hand or use the chat box. So please attempt the questions, Dr. Okafo and Dr. Okeke. Dr. Okeke, Dr. Okafo, are you there?
Yes. May I be here?
Okay. Yes, please go ahead.
Okay.
Dr. Adebayo will come to you in a moment, sir.
Someone asked if there are grading scales for craniosynostosis. I didn't come across any grading scales for craniosynostosis, but our teachers can help us if there are anything like that. I didn't come across any. For the fontanelles, okay, he asked about intrauterine and extrauterine deformity, or extrauterine deformity. Actually, craniosynostosis could be an intrauterine or an extrauterine deformity, depending on the severity. As I presented, there are many factors that predispose a patient to this abnormality. If those that are caused by mechanical factors, especially by multiple pregnancies and oligohydramnios, it could actually start in the before birth, in the prenatal period. Yes, because of the limited intrauterine space available for the child or for the baby. So it could happen in the intrauterine period, or it could happen on the prenatal period. It could happen postnatally, depending on the cause, the predisposing factor.
Yeah,
Yes.
you'll get me.
Hello, can I be heard?
Yes, please go ahead.
Okay, okay. For the number of sutures, number of fontanelles in the uterine and postnatal period, I can't put a hand to that now. But I know that it is not only the anterior and posterior fontanelles we have. We have others, minor fontanelles that that are actually closed earlier than that. But I don't know if they get that number for now. Thank you very much.
Okay. Let me
Okay, I think let me answer the fontanelles. There are 6 in numbers. The anterior and posterior, then 2 mastoid and the 2 sphenoid. This is for the extrauterine. The intrauterine, I'm not so sure, but I know that 6.
Do you mean 6 intrauterine and 2 extrauterine?
No. I mean, for a newborn baby, they usually have like 6. One anterior, then the posterior, then 2 mastoid and the 2 sphenoid.
Okay, I hope you are not mixing it up. Intrauterine, there are more 6.
Intrauterine are 6, then extrauterine are 2.
All right, so that's more like it.
Sorry.
Yeah, okay. And then concerning whether craniosynostosis are intrauterine or extrauterine, I mean, I think you must have told us that most times they are born with it, so they are congenital, except for the secondary ones that are mainly, extrauterine. However, there are more questions for you, so let's go on with it.
There are more questions.
So Dr. Udoimo wants to know what is virtuous rule and what determines cranial vault growth. Do you get those questions? Please be noting your questions before we call on people who would like to ask their questions. Should I state it again? What is virtuous rule?
What is virtuous rule?
Then what determines cranial vault growth?
Virtuous rule, what determines cranial vault?
So Dr. Abdul Karim said, can you shed more light on endoscopic strip suturectomy? And are there centers in Nigeria doing this procedure? Another question in the chat box is that in the treatment approaches, please be noting all these questions. Are you getting them?
Yes.
Be noting it. Dr. Adebayo will call you in a moment, sir. In the treatment approaches, can we know the age period for the different approaches and the advantages over the others? So the participant wants to know whether there are some procedures that you cannot do at a particular age. Have you gotten all those questions?
Yes.
Okay, so let's call on Dr. Adebayo, pending when you are ruminating on your question, to ask his question. Dr. Adebayo, sir.
All right, thank you. It's actually not a question, just a few comments and contributions. Thank you, the presenters. You did a good job. I can't remember doing any case of craniosynostosis as a resident, but now during my fellowship is a lot of work on craniosynostosis, which we do every week. I'm going to start with a few comments. So basically, for now, for children who are less than 6 months, the gold standard is for you to do endoscopic suturectomy for patients that have simple craniosynostosis, whether coronal or sagittal. And the advantage of that is that you're just going to make an incision, which is just about 3 to 4 centimeters long, remove a strip of bone on both sides of the sutures, which is just about 4 centimeters in diameter. And most of the time, you're going to put them in what we call an helmet, just to help with modeling the head of the patient, and that helps a lot. But that becomes challenging when the patients are more than 6. Some people actually stretch the endoscopic one to like 9 months, but it's kind of difficult. But when you do it at less than 6 months or up to 6 months, it's kind of very favorable. That's for patients that you can follow up on a regular basis and mold their helmet every month or every 2 months, depending on the schedule. For patients who live far away, and you know that you may not be able to follow them up very well, then you do what they call the suturectomy with biparietal morcellation. So the picture I actually showed for the suturectomy looks a little bit more like the morcellation. But in addition to all those lines that you have on the side, you are going to cut them like a pattern, like different squares that are interlocking or interconnecting. And then, even if they do not come back for ailment or remodeling, the bones are going to heal and the head is going to take shape over time. Now, for patients who are more than 6 months, or if you stretch it 9 months, then most of them will actually require, especially for those with a coronal frontoorbital advancement, which we talked about earlier on. But most of the people now are tending to early diagnosis and doing minimal surgery, because that's going to reduce blood loss and the risk of infection. And you're likely going to get a better outcome in these patients, which is now the gold standard. That's my comment. The other thing you need to be able to do is that when you are looking at patients that have the metopic sutural craniosynostosis, you need to be able to differentiate between the region and actual, craniosynostosis, where you have the pointed triangular forehead, which is called trigonocephaly. But for patients that have just region, you're not going to have that, abnormal shape of the head, and you're not going to see what they call the omega sign. So when you do the X-ray or you do the CT, you're going to see like a groove on the inner side of the bone. That's called the omega sign, and that's classical for the metopic. But by and large, I think they've done a good job. A lot of times now, except when you do the morcellation, a lot of people actually do not put drain. So you can actually do this surgery if you minimize blood loss intra-op and get away with, putting drains to the patient. And most of the time, we just keep them for 2 days. They go home and they come for follow-up. That's just my little contribution. Thank you.
Thank you very so much, Dr. Adebayo. Dr. Okafor and Okeke, can you answer your questions before we go to our faculty of the day?
Yes. Okay, someone asked what determines the cranial vault growth. What determines cranial vault growth? One of the primary determinants of cranial vault growth is the growth of the underlying brain. Yes, because secondary craniosynostosis is actually caused by failure of brain growth, which will cause those just to few. So if the underlying brain is growing as it should, the cranial vault will also expand and grow. Another thing is some growth factors that are present at the sutural lines. They serve to balance the process of differentiation, and apoptosis. When there is imbalance between some of those processes that take place at the sutures, then these bones will fuse and lead to craniosynostosis. Moss also was of the opinion that formation of the cranial base will determine how the cranial vault will form. So if there are problems with cranial base formation, that also manifests on the cranial vault. So that's actually craniosynostosis is an it's a neurological field that is still expanding. There are so many molecular theories and knowledge that is still unfolding. It's an evolving area. So as knowledge increases, we'll get to know more about the processes that lead to barbarian growth. Concerning virtuous rule, as you said, I don't have any idea what the rule is about. I didn't come across it as I was preparing for this presentation.
Okay, I think well done, Dr. Okafor. But interestingly, you mentioned the virtuous law when you were presenting. Apparently, maybe you didn't pay attention to it. And it basically talks about the growth of the skull. Naturally, in a normal growing skull, the head grows in a perpendicular direction. For an early fused suture, i.e. in patients with craniosynostosis, then the growth of the head is perpendicular or in line and parallel to the growth. The growth of the head is in parallel to the closed suture, and that is what the virtuous rule talks about, or the virtuous law. Somebody is asking about the cephalic index or the cranial index. What is it? Dr. Okafor.
Is it for the cephalic index? No.
Did you come across the cranial index?
No. I don't know what that talks about.
Okay, so the cranial index, that's the ratio of the transverse diameter of the brain versus, i.e. the biparietal versus, the diameter of the skull. times 100, and then it's measured in percentages. So I think those are some of the things that's used to know this severity of craniosynostosis.
Thank you, sir.
So it's the width against the length of the skull times 100. Okay, so another question here, what are the number of operations done monthly or yearly? I think this might be difficult to answer, except if you have a central data where we could get that. From the name, I'm suspecting the person that asked this question is Dr. Gapo Monang, possibly one of our international audience. Except if you have the answer to that, Dr. Okeke, what are the number of operations done monthly or yearly? Whether in your center or if you have any data about the national number.
Unfortunately, I did not get that information. But in my center,
Okay.
I don't think I've seen that one. I did not check across the country or even across the world in the general.
Okay, so it has been a robust discussion so far. I think it's time to introduce our faculty for today. I'm sure has been waiting to be part of the discussion. It is my pleasure to introduce to us this evening Dr. Gians Marcus Boat. Dr. Boat started his education at the Air Force Primary School in Jos, where he graduated in 1988. He attended the United Faith Tabernacle College in Jarawan, Kogi in 1991. There he proceeded to the Government Science School in Kuru, where he finished in 1994. Dr. Bott's medical school was at University of Jos, where he completed his study in 2003. Dr. Booth actually remained in Jos, where he joined the Jos University Teaching Hospital. And then in October 2018, he bagged his Part 1, which is now called the membership exam of the West Africa College of Surgeons. From Jos, Dr. Booth traveled north into Usmanu Danfodio University Teaching Hospital, Sokoto, to train to become a neurosurgeon under one of our leading forefathers, Professor P.B. Shehu and Professor Ismail Nasiru, where he obtained the fellowship of the West African College of Surgeons in neurosurgery in April 2014. Dr. Both actually also have fellowship in pediatric neurosurgery in Dana's Children's Hospital, far away in Tel Aviv, Israel. In November 2015, under the guidance of Professor Shlomini Konstantini, who is the immediate past president of International Society of Pediatric Neurosurgeon, ISPN. Dr. Both is also an international visiting fellow of the WNS of the University of California in San Francisco, and also that of Barrow Neurological Institute in 2017. He's as well a research fellow of the Barrow Neurological Institute in 2019 under the world-renowned Dr. Michael Lawton. Our faculty for today, Dr. Both has published in both local and international journals and is a regular attendee in both local and international conferences. Dr. Both has particular interest in pediatric neurosurgery, vascular neurosurgery, and neurosurgical researches. He is an avid reader of inspirational books. Dr. Boat is married to Dr. Kachelon Boat, a pediatric resident who is rounding off her program, and they are blessed with children. Dr. Boat, sir, the floor is yours.
Thank you very much for the opportunity. Trying to share my screen. Can you see my screen?
You will have to, okay. Dr. Okafor, can you stop sharing, please?
Thank you very much. Can you hear me? And can you see my screen? Can you see my screen?
Your screen is not visible yet.
Maybe you. is
Yes, it's visible now. It's visible now, so you can just put it on
okay.
slideshow.
Okay. So thank you very much, Dr. Oshola. It's a pleasure meeting you. I think the first time we met was in Denver during the ISPN conference when the late William Harkness was ISPN president. So thank you very much for this opportunity. Just to round up and say a little things is mine. I will just be saying a little about the practical approach. Craniosynostosis, as my disclosure, I would want to deeply appreciate all my mentors locally and internationally, and also to say that a lot of the images are from my mentor, Shlomi Constantini and his team, where I did my fellowship. And I'd just like to be, mine would be more practical and to just tell you certain things as with regards to the principle of the management of these patients when it comes to surgery, and more of pictures for just appreciation a bit more. It's important that these patients, as we prepare them for intervention, that we make the clinical assessment. And as presenters have said, the diagnosis is mainly clinical. But if you're not very sure, then there might be a place for CT scan. And the blood workup is very important because we need to know whether this patient has enough hemoglobin and does this patient have some clotting dysfunction. And also preoperatively, it's good to counsel these patients because some of the things that they may experience, especially post surgical intervention, that's the big surgery, not the endoscopic ones, will be that the patient would have some swelling of the eyelids and may have fever. So when the patient's relatives are aware that these things are coming up, they would be less frightened when they see the child afterwards. When it comes to intraoperatively, you need a good anesthesiologist who is familiar with this condition, and if possible, put an arterial line so that you know the blood pressure per time, not that when there's an issue, then you get into trouble. So the next would be the positioning of the patient. So the positioning will depend. For example, if you're doing a strip colleagues have said, and then the hello. Can you hear me?
We lost you for a moment, sir, but you can continue now.
Okay, okay. So you try to be as fast as you can also. And my mentor believes in starting transfusion from the beginning of surgery. And Rainey's clips, diatomy, gel foam, Surgicel are some of the things you need as well as drill if possible. And post-operatively, you need an intensive care. And that is why it's important that we start developing our pediatric intensive care where patients can be monitored and correction of anemia can be done as early as possible. And I told us about some of the post-operative expectation. And the type of surgery would depend. So for example, this is a child with a scaphocephaly. I left this here I don't know whether you can see my arrow.
So we can.
Okay, so the patient is in a prone position, and yes, my mentor, which is his technique I use, he uses an S incision, kind of an S incision, and here is a beanbag. The beanbag is suctioned, and it keeps the child in a prone position. So this child is in a prone position, and you put some padding of some foam by the side here. And these, in this case, you just do a suturectomy. You remove the sagittal suture completely here. And as I said earlier, in children, you are not, early, you don't so much worry about the defect, because in adults, you're concerned about the defect. But when you take that, the bone will heal over. This is for a late scaffold, for example. So you can see that the child now has the zigzag incision that we talk about. But in this case, the patient is not supine, sorry, is not prone, but supine. And a little foam here to ensure that you don't kink the venous drainage of the head, so that you don't also have increased bleeding, and also elevate the head above the heart, so that it also reduces the bleeding. Now, we see here that if you are doing a regular strip cranectomy, which was the first in early scaffold, which usually would do for a child around 2 months, you would remove the whole, sorry, I don't know what, okay. My arrow not showing, but the image to my left, if you do a strip cranectomy, you remove the whole of this bone. You remove the whole of this bone, and you break the bones like this. But usually you cut it with the scissors. But the problem is when you watch is that when you strip the periosteum here, when you're cutting, you ensure that you don't cut what? To the skin. So ensure that you cut downwards and do not cut to the skin. It's important to know that craniosynostosis is like an art. So it's one area that you find different techniques. So unlike what our other colleagues, my other colleague showed, where you just cut here, my mentor prefers that you cut a bit here. And see, for the late scaffold here, besides you leave a strip of bone in the sagittal sinus, cut in front here and also posteriorly. And then by the sides, you do these strips or bevel, as my other colleague said. In front, what you do is that because there is a frontal bossing, you cut a little in front this way and on the other side, and you break it down, break it a bit backwards. Here also you do green stick fractures, but green stick outwards, so that it also opens the head. And this is the outcome of that surgery. Now, this is another case. So you see here, you keep some of the bones by the side, and particularly when it comes to older children. You can see the frontal bossing here and the correction here. For anterior plagiocephaly, you can see here also is flattened, and here is the new forehead. This is the orbital bandeau here. Here's the orbital bandeau. And on this side, that has the plagiocephaly, an absorbable plate is used. Here, in the past, what my mentor was using was he would take a template, which was like hexagonal, to the normal side, and then cut the piece of bone. But subsequently, what they do is come in here. If this was the normal bone, you cut a little above where it is more normal, and you make it the new forehead. And you need to put some Surgicel and gel foam, which back home was a bit of a challenge. And here's the reconstruction. So here is our case with some of my colleagues here. This was a case we did, and you can see the anterior plagiocephaly here. And this child came to us, and we had our own challenges. One, we didn't have the absorbable. So CT is not a requirement, but you can see here when you're not sure and you are starting, it's better to do. But usually by standard, the diagnosis is clinical. So here, my images are not so good. Here's the area of the plagiocephaly. Here is the orbital bundle. And here, see, we're advancing it forward. We are advancing the area of the plagiocephaly, moving it forward. And you can see that we moved it forward, and it's even more forward than this side. And the thing is that you overcorrect. The encouragement is that you try to overcorrect. Now, this is the lady post-surgery, immediately after surgery, here, and with her consent. A few years later, you can see that even with our seemingly overcorrection, she still has something, but I think she's much more beautiful than she would have been. This is our second case with some of my colleagues who are here. As a child who came and somewhere had a shunt inserted because the person thought that the head was very big and went ahead and inserted a shunt. So when we did a CT, we noticed that there was no hydrocephalus really. So what we did here, as you can see, she has brachycephaly with or also satoriccephaly. So here, I would move this a bit. Oh, sorry. So here, I can't see that very well, but you can see where our orbital bundle is, where it should be. And what we decided to use was you can use bone struts, part of the bone that you have. You can use it as the absorbable plate. And this is the reconstruction you can get. But I just want to know that there are occasional cases that it may not just be the regular craniosynostosis. We had a case of hyperosteosis, which the thickness of the bone was much thicker and the bleeding was more significant. So you have to, that's a place that you need to just watch out for. So here is the child. Here's the orbital bundle. Here's the new forehead. And we can see that the head is much better than it was. Sorry, digital issues. I don't have the most recent images of this patient. So for metopic, and just to mention that you can have a child that has just a metopic ridge. I remember one of our secretaries back home came, and what the child had was just a metopic ridge. You could just feel a ridge over, not like this, So in that case, you really don't need to do anything if it's just a ridge, except really worried about. And you can see this reconstruction and the outcome. Now, sometimes they don't use the clips, the suture with Vicryl. So you can see sometimes you can also cut the bone on this side, and then the pericranium being brought anchored, the temporal muscle being also anchored. So you need gel foam. You need gel foam to pack the space, and that was some of the challenge we had back home initially. We didn't have gel foam when we did those initial cases. So as you can see here, the temporal muscle and the pericranium approximated upwards. Now, I'm more familiar with the open technique, and for the endoscopic, from my opinion, it's not a difficult technique, but the main difference is that while the endoscopic is minimal blood loss, but you need to have the child on helmets for many months. And I think I make it akin to when you have a case of you go and clip and you settle it for a while, or you do endovascular and you have to put the patient on antiplatelets. Even though the arguments as to the outcome, whether which is better or they are about the same, but definitely blood loss is less and usually better when the child is much younger. And so no images for that. So I just want to say thank you for the opportunity. And to just mention there are other things, just to comment that these patients, you have to watch out for amblyopia. And so the child with craniosynostosis also need to have an ophthalmology checkup, because you can have the lazy eye and eventually the brain will not be able to register very well. So one eye can become reduced in function. So it's important we do that. And I don't know whether that's my opinion, but I think maybe also the way we mold, I think we have less compared to the West. Maybe the ways our mothers and grandmothers mold the head also after childbirth, maybe it has something to improve that. So I just want to say well done to the presenters and thank you for the opportunity. And here are some of the early works when we were seeing. We saw a work by Ibe on suturectomies on Odeku. When he came long time, he did some craniectomies or so forth. So we did anterior cranial remodeling and orbital advancement, and I want to say thank you. And just to mention, we had a case also that you can have anterior plagiocephaly with an isolated frontosphenoid craniosynostosis. So you may have plagiocephaly and the coronal suture is in place. So we had a few, one case, I think, one or two cases or so. And I think it's also rare. So thank you very much for the other people in the country that have contributed more to congenital malformations.
Thank you so very much, sir, Dr. Graham Booth. That was a very, impactful and loaded images. Beautiful pictures, I must say. Thank you so much, sir. A quick one before we go to some of our senior participants. I noticed Professor Jimo started this program with us and is still with us. Thank you so very much. I can also see, I know I've been saying Professor Ismail Nasiru all day. I don't know whether he's still around. Dr. Ayodele, one of my trainers, has also been around. But before I go to them, if they have any contribution to that, Dr. Potts, I don't know whether you have any experience of strip craniectomy being done in children with very big head as a result of hydrocephalus. I know that one of my trainers wanted to do that in a case. There's this child with neglected hydrocephalus. The head was so very huge, and then it's creating a very grotesque cosmetic issue, and then we are considering whether doing a strict craniectomy might help to reduce the size of the head. Do you have such experience, sir?
Yeah, okay. I know my mentor does not like cranial reduction surgery. He doesn't like cranial reduction surgery. But we had a case while in Jos. I think that's the third case that we did. Either the third or the fourth, which was not craniosynostosis per se, but we did some form of cranial vault. What happened was that patient had a double hydroencephalocele, one in the anterior fontanelle and the other was posterior encephalocele. So an occipital encephalocele and one in the anterior fontanelle with hydrocephalus. And I think I would term it close to like the volume of the fluid was close to a liter. And so for that patient, we did some remodeling of some sort. We by the sides laterally, we did excised, we did some form of craniectomy, and we cut the edges of the bone laterally, like the way it's done for scaffold, and we brought it back a bit. So that's what we did for that patient.
Thank you so very much, sir. Yeah, now back to our other senior teachers, international participants. Professor Nasiru, I don't know whether you have comments. Professor Jimo, Dr. Ayodele, if you have any comments, I would love to have them, sir. Thank you so much for being part of this since the beginning.
Good evening.
Good evening, sir.
Yes, I'm Jimo. Thank you so much. Thank you so much to the presenters, the moderator, and the faculty. Obviously, he has both the presenters have gone to town in really discussing the matter. And the discussion has been quite robust, and the moderator has really summarized a lot of things, especially in a practical way, because apparently he has a lot of hands-on. There is little to add. My own little input usually is, in this regard, is to make sure you make the diagnosis before you do anything to the patient. A patient might have microcephaly because the sutures are fused, premature fusion, of course. In an instance where there is hypoxic injury somewhere, then you think it's some craniosynostosis. I don't know if the presenters know something about Zika's disease, Zika's infection. I've seen an instance where somebody, a colleague, sent a patient with Zika's disease to me, thinking it was kind of craniosynostosis. Of course, we had to discuss with the referring doctor to enlighten ourselves on that stuff. Like the presenter said, it's a variety of varying disease spectrum, and therefore the knowledge is also running a lot of varying spectrum. The moderator said what his mentor or his teacher prefer, while some of us have been exposed elsewhere where some people prefer other methods. Is indeed a wide spectrum. So one of the presenters talked about a multidisciplinary approach. Yes, before actually going about or indulging, I think you should consult. There should be a lot of multidisciplinary meeting, because the ophthalmology, sometimes the syndromic types that come with a very shallow orbit, you have to consult with the ophthalmologist, in addition, the plastic surgeon, so that you people plan on how to get the best of results out. Sometimes, of course, the vision can be compromised, so you have to consult widely and do MDT, multidisciplinary discussion to to know how you get the best out of the surgery. By and large, in summary, it's been a fantastic discussion. It gave me serious insight into the whole discussion on craniosynostosis. Thank you so much, everyone.
Thank you so much for your contribution, sir. Professor Nasiru, sir, I don't know whether you have some comments for us, sir.
Yeah, it's a very interesting and wild, very good presentation. I really highly commend the presenters and all the discussants. I don't know why we are not getting them already here, or probably they have been going somewhere else. We used to have them here in Sokoto initially, but in a couple of years now, I've not been seeing them. So it's good that we keep up this technique and continue. I hope we'll start doing some gene assay if there is any center in the country where they are doing this gene assay. So we can be sending the samples and the tissues to that center, so that at least we can have our series and what type of mutation we are getting in our patients. Thank you very much, Dr. Bot and other presenters. It's an excellent presentation. Please keep it up.
Thank you so very much, sir, for your insights. Dr. Ayodele, sir, I don't know whether you have comments for us too, sir, and any of the fellows among the participants.
Good evening, everyone. It's been nice joining this meeting, and I've thoroughly enjoyed all the presentation and the ensuing discussion that followed. I think the presenter have done a very good job. It's also very nice to hear my good friend, Dr. Bott, who has a very rich series on this craniosynostosis surgery, and to appreciate the good work he's been doing. From our end here in Lagos, we have done quite a lot. It's not what you do quite commonly. I would have loved to, but I think I just pointed to that. Love to hear from Dr. Bott if you can adapt this to some reductive cranioplasties for some of our big-headed hydrocephalic patients. But I recall he said it's not something that his mentor, Constantine, does so much. I would love to hear his thoughts on that. Because I've seen a number of patients, not craniosynostosis per se, but with huge grotesque head size, that are now desirous of having some form of cranioplasties to address that for cosmetic reasons. But by and large, it's been a very interesting and engaging discussion. Thank you very much.
Thank you so very much, sir, my Oga, for your contribution. Dr. Adegboye, ask Dr. Bott whether you advise what his advice is in a patient with craniosynostosis, which is concomitant with hydrocephalus, and same patient with raised ICP. He wants to know whether you advise an initial CSF diversion, especially if definitive surgery cannot be done at the time. So concomitant hydrocephalus and craniosynostosis in the presence of raised ICP. What is your advice, Dr. Bott?
Thank you very much. I don't think it's a question that has one directional answer. So it may be based on preference and your thoughts. For me, I would prefer to do the cranial remodeling first. My reason to do cranial remodeling first is that I don't want a shunt infection. I am scared of the shunt infection more than the biggest surgery of craniosynostosis surgery. So I would rather repair so that by the time that cranial remodeling also gives some space because it's like part of the bone that open. So it gives some room. And by the time your wound has healed, then you can go ahead and insert your shunt. The other will be to do both at the same sitting. But as I said, my concern is with regards to getting a shunt infection. I wouldn't want to have a shunt infection. So my preference as a person would be repair the craniosynostosis. One, it takes the pressure off. Two, it gives openings. And without those openings, it now allows for the reduction in the pressure. So I think that's my thought. Do cranial synostosis surgery when there's no infection, nothing, insert your shunt. And for cranial reduction surgeries, as I said, my mentor says, so most times we tend to move towards the thoughts of our mentors. But there might be a place, but I think it's that maybe if the patient becomes an adult, you can still remodel of some sort, but I think my thought also is, except it becomes very necessary, let the patient grow and meet up with his head size.
Thank you.
It can be done, really. It can be done.
Thank you again, Dr. Bott. There are a number of thank you in the chat box. Everybody is really excited and happy with the discourse so far. I think I saw the electronic hand of Dr. Bamidele up the other time. Adebayo. Dr. Adebayo, do you still have some comments before we round off? Dr. Adebayo.
Yeah, I was just going to make a comment about the patient that has hydrocephalus and may not be able to get surgery now. If the patient has symptomatic hydrocephalus, definitely makes sense to put in your shunt. If you do your aseptic technique very well, that should not increase the risk of infection. Just like Dr. Bott said, I know that when you do the expansion, definitely it helps the pressure, but sometimes that may not take all the pressure off. But that's another thing you can actually do, especially when you don't have the expertise to like do the craniosynostosis immediately. So it's an option to actually put in the shunt first, and then when you're doing the craniosynostosis surgery, you just need another shunt prophylaxis antibiotics. That's what we do where I am right now. And most of the time you escape with infection.
Good. Thank you so much, Dr. Adebayo, again for your own contribution. I think so far it has been a very robust evening, been very entertaining, very interactive. I think everybody who have been part of this have really enjoyed it. I have in more ways than one. If there are no more comments or questions, I would like to hand over back to the YNNF ESCO, and then thanks for having me.
Okay, let me just mention something that also for children who have slit ventricle, but coincidentally, I don't know whether it's the Shabra shunts we are using, but because I have not seen many slit ventricle syndrome in our environment. So, but for those who have, they may need something like a cranial expansion surgery for that. So it means relatively that a patient with a shunt can still go ahead and have those kind of cranial surgeries, as Dr. Bamidele has mentioned. So patients who have slit ventricles, when steroids don't work, some of those other things don't work, you may need to do a cranial expansion surgery, which is a brother to what we do in craniosynostosis.
Again, thank you so very much, sir, Dr. Boots. YNNF chair, sir.
Yes, thank you so much, Dr. Oshola. Really, I'm tempted to go through a long list of appreciations, but maybe for want of time, I might just have to resist that temptation. But kindly permit me to appreciate our presenters for today, Dr. Sakapo and Chike, who set the tone, set the ball rolling, that got us through this very beautiful session this evening. Our moderator, Dr. Oshola, for an excellent job. Dr. Bott, our faculty, really interesting discourse, and obviously everybody has enjoyed it thoroughly. I appreciate our senior faculty who contributed, Professor Nasiru, Professor Jimo, Dr. Bamidele, and our international attendees for making it a date with us. I would also want to appreciate the webinar committee headed by Dr. Adeboye, who is our coordinator webinar. It's been a wonderful job, and we really appreciate you and everybody who's here. Thank you so much for the job. Thank you everyone for making it this evening. We're looking forward to another interesting topic next month by God's grace. You have a pleasant weekend ahead. Bye-bye.
Thank you.